Good morning and welcome back to Coding with Christine Hall. It's so nice to be back. Last week I was on vacation in West Virginia in the mountains. Beautiful, beautiful part of the country. And I brought home a nice sinus infection with me. So the cold weather up there just didn't agree with me very well. If you are in that northern part of the country and you're experiencing cold, oh, I send warm wishes to you. So, today I thought we would chat about some of the changes that we're seeing in CPT. So, I know a lot of us are just now getting our CPT books. I'm still waiting on my actual book. I have my ebook now, but I'm waiting on the actual book. AMA said that they're a little bit behind. Apparently, we all want new books. So, they're coming, guys. Rest assured, they're coming if you haven't already received yours. But there was so much great information in this CPT book. I know that anybody who has listened to me talk, um, CPT really does a great job of helping us. We just have to know where to look, right? So I tell my students all the time it's not a matter of memorizing everything, but knowing where to find the answer. So I thought maybe I would share with you some of the highlights that I saw that really excite me about some of the changes in CPT. So let me share my screen with you just a minute here. Can you all see my screen okay? Hopefully. Yeah, there we go. Oh, right on. Okay. So good stuff here. 405 changes to CPT. So 249 additional codes, 63 deletions, 93 revisions. Most of those revisions are editorial. Revisions where they've either added some information or deleted some information from an already existing definition or instruction to a CPT code. So the other thing that was kind of cool is that we got two new appendixes in CPT for 2022. Appendix Q, which is a great table for the COVID vaccines. So the administration codes for COVID vaccine for that first dose, second dose, and some of us that are eligible for the third dose of either Pfizer or Moderna or the Johnson and Johnson. So that is an awesome, awesome appendix that was offered to us. The second appendix, I was even more excited about. So, remote patient monitoring is something that is so new, and it's helping our patients so much having that remote patient monitoring. But there's so many different codes, and how do we know which code we should be using? Whether it should be an office visit or it should be chronic care. We have principal care, transitional care, so many different types of care management. So, Appendix R is this awesome, awesome table to help you with finding out which one of those digital services is most appropriate for your organization. We did have a few changes. The chronic care management code just had a few grammatical changes to it. The 99491 was revised. That is a chronic care management code. And it now gives us elements that are required as part of that code. So if you look over here, you'll see that AMA has expanded the requirements or the expectations of chronic care management. So of course, we always had two or more chronic conditions that are expected to last at least 12 months or until the death of the patient. Those chronic conditions place the patient at significant risk of death or exacerbation or functional decline, and that there's a comprehensive care plan that has been established, that it is either implemented, revised, or monitored when we're using that code. And the 99491 is for each 30 minutes. We did get a new code, was 99434, and that's for those additional 30 minutes of chronic care management per month when they are supplied by the physician or the qualified healthcare provider, that your nurse practitioners, your physician assistants there. So I thought that was really cool. But one of the more cool things is that we have uh, more definition, for chronic care management, more instruction, more parenthetical advice that is all listed right here in the CPT book. So it goes on to talk about things like the care plan, the difference between the 99490 and the 99491, 0 being clinical staff time, 91 being the physician or the qualified healthcare professional. And then, of course, the complex chronic care management, we got that a couple of years ago. So we got some more definition for that. One of the coolest things I found was, we talk about care plan. As an auditor, I'm constantly talking to my providers about a proper care plan for chronic care management. And, there's been a lot of guidance out there, most of it's CMS based, but what about, AMA and those commercial payers? Do they have to follow? How does that whole thing work, right? But we have some clear definition in CPT now. So the plan of care, they gave us some recommendations of what it should include, like a problem list, expected outcomes and prognosis, measurable treatment goals, right? Measurable meaning that, maybe we're asking our patient to go to the gym 3 times a week, and we're monitoring that. Hey, are you able to get out 3 times a week and do those exercises that are so good for your hypertension, your cholesterol, those types of things? Cognitive assessments, functional assessments, symptom management, right? How's the patient doing with all of that? Planned interventions, medication management, environmental evaluations. If you've heard me talk recently, I'm a huge supporter of telehealth. And I heard a story the other day. Actually, I read it in a patient's note where they were seeing their dermatologist for years and years and years. Finally, last year they had a telehealth visit. And during the telehealth visit, the dermatologist looks behind the patient who's sitting on her back porch and sees this type of bush or shrub that, through allergy testing, she's highly allergic to this bush or shrub that was outside her window. And for all the years that the patient was seeing the dermatologist for this rash that she would get the reaction for, um, never once did it cross anybody's mind that maybe she had that allergen right there in her house. So they were able to treat her. So environmental evaluations, that can be so very powerful. Interaction coordination with other resources, healthcare providers, and then maybe a summary of the patient's advanced directives can all be included, or components of that care plan there. So I really loved the fact that they gave us this additional information in CPT. I think that's one thing that's lost when we just go in and say, okay, what are the new codes? What are the deleted codes? We miss that there's so much instruction that's added every year to CPT. That's kind of my main focus today, is just to share with you that there's so many changes that were made. We have new permanent principal care management codes. So that is where a patient has one complex chronic condition that is expected to last only 3 months or longer, but does require that significant care there with that patient. So we have these different codes there. And if you look at the bottom here at this slide here, it says that the codes also expand remote physiological monitoring codes. So we have a lot of that built in. When we talk about care management, whether it's chronic care management, principal care management, transitional care management, there was always, again, this kind of question of what type of activities really count towards chronic care management or care management. Again, CMS is always more forthcoming with that information. It's easier for us to find. It's usually our go-to. But it's so nice to see that the AMA got on board and they're helping us as well for those commercial payers, or, again, to help support coders with their providers, right? What are those activities? So they broke those activities down, telling us about the communication with the patient, with their caregiver, with their home health agencies, any assessments or support that is provided. They gave us this really great list that we can follow. And they even went further on to make sure that we understood what the practice needs to be able to provide to the patient. So, again, what are the expectations from a clinical perspective, but also what are the physical expectations? So, the chronic care management must provide 24/7 access to the physician or qualified healthcare professional when they need urgent care to resolve an issue. So, the patient should have some sort of an access. Providing community care. So we're the excuse me, continuity of care. So we are also reaching out and talking to those other providers. I saw my orthopedic doctor today, and he made a point to write a note to my rheumatologist, right, to make sure that this care is being provided with the multidisciplines there. Um, a lot of great information, and they remind us that we can't cross these management services. So we can't cross chronic care with principal care with transitional care. We need to be very careful that the time that we're providing our patient is very well documented to support which type of care service is being provided. So I really loved that information that was given in CPT. We had a few changes, I mean, additional codes that were added to anesthesia. We had two codes that were deleted from anesthesia. The integumentary system only received one change, really. That was the insertion of a drug delivered implant there. So they took out the non biodegradable and they put in a bioreabsorbable, biodegradable, and non biodegradable. But if you look here, the cool thing is that they also have these parenthetical notes. So they tell us that if we're removing a biodegradable or a bioabsorbable implant, which code we should use. Some new fracture codes that were added for the musculoskeletal section. Again, great documentation there to help us if it's a closed treatment of a nasal fracture bone without manipulation or stabilization. That's just going to be an evaluation and management visit. So a lot of guide is there in these instructional notes. We had some revisions to the arthrodesis codes, as well as a lot of great new parenthetical notes and direction when we are doing arthrodesis with patients. So I hope you're not just looking at the new codes or the revised section of those codes, but you're also looking at all of the instructional information that has been added. So again, some more on the arthrodesis here. We did get some very clear instruction of, two surgeons that are doing an arthrodesis together for a spinal deformity, how those should be reported, and what additional codes should be added or not added when reported in documentation. We did have a deletion of a nasal fracture code, and they gave us some advice that if we do have to report that type of a fracture code, we should be using our evaluation and management. So it's always in a couple of different sections as well if it needs to be reiterated. Again, here are some new codes that we have for the cardiovascular section here. We have a lot of great instructional information when we should not be reporting codes together or during the same session. We also have some deleted codes that were included in this. Not too many deleted codes for cardiovascular, more the additional codes that are added on there. More cardiovascular codes for harvesting. And I will tell you that the respiratory system only had one type of instructional note, and that was to not report a diagnostic laryngoscope in conjunction with some of the other scopes that may be done with the patient, or some type of an speech therapy that might be done with the patient at the time of service. So take a look at that. It's going to be right there in the instructional section for respiratory. Take a look at, again, all these instructional notes that talk about harvesting the upper extremities, those arteries there that might be for a bypass graft, things like that. They give us some good instruction if we need to report a bilateral procedure or when we should be adding a procedure or not adding a procedure code when it's supported. Moving on to the digestive system, not a whole lot in digestive system, more so that there were some do not report certain codes with other codes or other procedures that are done on the same day. Um, two new codes here and two deleted codes in digestive system. My favorite system of all time. I'm not going to lie, I love the digestive system. Fascinated with it. Urinary system, male and female genitalia there. So we did have some types of codes that were added for balloon incontinence. We had some revision of codes. We also had some instructional information, do not report or report with specific codes there. Only one deletion. It was for the surgical treatment of an ectopic pregnancy interstitial uterine pregnancy, which requires a total hysterectomy. And I would imagine that that was probably deleted because it just did not have enough use um, for that code. Moving into the nervous system, we have some new codes for that laser interstitial therapy, thermal therapy for lesions. Again, these are lesions that are on the nerves. There's a lot of great instructional information. Um, I think on my next slide I have okay, there's some more some more revisions. So they're getting away from incision to more of the word open, and that's how we as coders look at things. Is it an open or is it a closed procedure, a laparoscopic procedure? What's going on? So they made some changes there. They added quite a few new codes here in the nervous system. Here are some more code additions to the nervous system and some instructions that were also listed as to when we should be reporting these codes and when we shouldn't be reporting, or any add-on codes, or even maybe an alternate code. So you see here for the insertion of an intraocular interior segment drainage device into the trabecular meshworks, we should be using one of our category 3 codes. So we did have a lot of category 3 codes that were added. Those are usually some of the biggest additions that we receive in CPT are going to be those category 3 codes. Again, there's some ophthalmology codes that were revised here. So they removed the one or more sessions, and they're just per per event. Oh, I lost my word there for a second. Gee whiz. Also, so there's a couple of other category 3 codes that should be used in case that's what better defines that procedure there. So some more in the nervous system there, some more of your ear codes there that have been added. We had some additions, we had some deletions, we had a lot of this great parenthetical advice here. So where a code has been deleted, they're telling you that there's now a new code that has a better description to support that type of service. I think I missed a note somewhere. I'm not sure. Anyway, radiology. Again, there not a lot happened in radiology. We only had a few codes that were added in the radiology section. There we had few codes that were deleted here in the radiology section, but a lot of great parenthetical notes, again, when we should and we shouldn't be reporting things in conjunction with each other. So one of the sections that got a major uplift, or a facelift, uplift, I don't know what the right word is for this, but it's going to be those laboratory services that are performed. So basically, like the pathologist's evaluation and management visits. So we have these new codes, and they follow very much the new guidelines for evaluation and management in an office setting. So if you look at this, if you look in the CPT book, you're going to see this table here, and it describes what a low complexity of problem from a pathology perspective would be. What is the data reviewed, again, from a pathology perspective? And what is the risk of treatment or testing from a pathology perspective in order to select the appropriate code? Same thing, it's only going to require 2 out of the 3 elements of medical decision making in order to select that level of pathology service. But definitely, I love that we're getting more towards these tables, and I heard a great presentation yesterday that said, once we build, I think it was Stephanie Scott that did this presentation, and she said, once we build that muscle memory, we've done it enough, right? I can tell you right now, I still have ICD-9 codes embedded in my head that I'll never be able to get rid of because we just use them so much, right? Anybody ever forget hypertension 401.9, right? I know it's I-10 now, but for some reason, when I think hypertension, bam, the ICD-9 code pops up. And that's that muscle memory. That's that brain memory because I just did it so much. These new guidelines will eventually become muscle memory, and you will be able to start selecting codes very easy. You're going to start thinking about the complexity of the problems, the complexity of data, and the risk. You'll start thinking of all of that in a much different perspective. So, if you struggle with evaluation and management, either from the office visit side or from a pathology side, you're not alone. I say keep at it, be persistent, keep pursuing those new guidelines until they start to become muscle memory. Don't give up. And here are those codes again. They deleted a lot of these pathology consultation codes and they added a more expanded pathology consultation again to incorporate those new guidelines of selecting a level of service, looking at the medical decision making as that key component or time as that key component. And time is going to have the same restrictions on these pathology consultations as they did with the office visit. So but if you're familiar with the time component and that's the way your pathologist decides to report those, that might be a little bit better. Um, there were so many additions to the lab area. I don't have all of the additions to the lab area. Again, those proprietary lab analysis codes, so many of those were expanded. And we also have other proprietary codes for laboratory services. So that always expands quite a bit. But I wanted to show you again that we've got a lot of parenthetical notes. See everything in green here? Those are those parenthetical notes that have been added to either changed or new codes to help kind of direct us in the right direction when to be using additional codes or not, really to support and edify these CPT codes. I know that a lot of times, the only time that I ever understood these types of parenthetical guidelines is when they were in the CPT assistant, which we all know we have to pay extra for every year. It's just nice to see them as part of the CPT book now that they're adding a little bit, not like the CPT assistant, but they're adding a little bit more information for us to use as coders in our book there. So that was great. Here are some new codes again for a lot of path and lab services. Even more codes for path and lab services. So if you're working in the lab or you have a lab in your office, take a look at these, share them with your provider, see if these are any of the services that are being performed in your practice there. So a couple of new COVID types of codes that were added there. And some of these codes may have been added earlier in the year, and maybe they just didn't make it in the past CPT book and they're making it to this CPT book. I promised you that one of the coolest things that we have is this Appendix Q in CPT this year. So that's really going to help us out when it comes to our vaccine administration. So if you're doing vaccine administrations in your practice, this was awesome that we have this Appendix Q. So of course, we're not billing for the actual vaccine because we're getting that for free, but we are billing for the administration here. And so AMA thought about the 3 doses and then even the booster dose, right? That has been, I don't know if the booster has been approved or not, but I know that the 3rd dose has been approved. So we're working that way. Um, so it gives us a great idea of the administration codes that we can be reporting in our own practice. These are the Pfizer administrations. These are excuse me. Then you have the Moderna administrations, and you have the Johnson and Johnson, the AstraZeneca administrations. I don't know that we're doing the Janssen or the Novavax. That would be something I would be interested in hearing if any of you out there are doing any of the Janssen or the Novavax vaccines here. I thought those were all like European vaccines, but there's 22 vaccines. It's so hard to keep up with. I'm glad that we're just kind of limited to the vaccines we have here. Anyway, those are those dosage codes there that you see. We still are doing our pneumovax. So we have a new pneumovax codes. We have a new hepatitis B code. And I noticed that there was a new gastrointestinal imaging code that was added. They do have some parenthetical notes here that advise you not to code this in conjunction with some of the other gastrointestinal tract imaging codes that that still exist. We have a couple of changes here in our 92065, and we have an addition of a 93319, and that's an add-on code for 3D echo imaging. So when it's done during that transesophageal echocardiogram, so that TEE, and as opposed to the TTE. So if you've heard me teach before, we TTE and TEE. Anyway. Quite a few deleted codes from the medicine section here that you should take a look at. Lots of changes to our heart catheterization. It's not even just the changes to heart catheterization, the extensive definition update to cardiac catheterizations is absolutely worth the read. So remember, everything that you see in your CPT book that is in green ink, that's all new instruction, new information. And I did see a few things that I had heard before, that I had seen before, but maybe it has been moved to a different section and now expanded upon. This is all new guidance, everything in green there. So again, some more medicine section codes there that you should be aware of. Some remote therapeutic monitoring codes there. That's new. So despite having our remote patient monitoring, we also have remote therapeutic monitoring. So remember that remote patient monitoring is for, we need to have an order, we need to have a condition, we need to be using a piece of equipment. We have to justify in the plan of care what we're using that piece of equipment for, what condition are we managing, what's the expected outcome. These codes are for therapeutic monitoring. Again, so we don't really have an exacerbated condition or a new condition that is not managed or not at treatment goal. These are those therapeutic monitoring once we've received that, once we're at that treatment goal, and to make sure we stay at that treatment goal. So, and here's that horrible 99072 code that has no value to it. It is a category B code, or considered a B code, which a B code is not separately reimbursable when reported, or reimbursable at all, but it is considered a component of any other service that is provided on the same day there. So I know a lot of providers are very proud of that 99072 code. However, there is no reimbursement attached to it. So will that change in the future? I don't know. It hasn't changed yet. It's been around since last year, and there was no discussion over putting any dollar value to it. So we have those category 3 codes, those unlisted, or we have permanent codes. There were 26 codes that were added to category 3 of the manual there, and they revised 80 of those category 3 codes. So that's that new technology that's coming around, new ways of doing things. Let's see. That's all I had to show you from a slide deck. That I'm doing a presentation for the AAPC Palm Beach chapter. Let me take that sharing off because that's kind of annoying. I don't know how to do that. Oh, great. So I'll be doing a full presentation on all the CPT changes, the things that you really need to know. I think that's going to be on November 17th through the Palm Beach AAPC. So if you go to AAPC and you go to networking and you pull up Florida and you go to Palm Beach, you're going to see our next um, yeah, the next event. You can also go to our website, Stirling Global Solutions, and on our homepage, if you scroll down to the bottom, you'll see all the events that I'm speaking at and all of the topics that I'll be speaking on. And of course, you're always welcome to join me. Let's see if we have any questions about some of the things that we discussed. Now, remember, in 30 minutes, there's no way that we can hit every single new code that is coming about, right? That's just not possible at all. So this was really just the like uber cliff note version of those CPT changes. Um, definitely. But so if you have any questions, you can feel free to email me. You can reach out here in the chat box. You can find me on LinkedIn. You can find our company on Facebook. We're also on Instagram. Make sure that you like our YouTube page. That way you get notified every time that we upload. So once in a while, I like to upload webinars that I've completed and just put them on the YouTube page. And sometimes that's really great information. And you'll know if you subscribe to our page. Anyway, I have one more quick thing I wanted to throw at you guys. Coming up next weekend, we have our Jolivet Medical Coding Institute second annual virtual business healthcare colloquium. And I will be speaking there, and along with me are going to be some of the top names of the industry, guys. Barbara Cabuzzi will be there, Jennifer McNamara there, the fabulous Kimberly Jolivette Williams will be there. And as a matter of fact, I think I have Kim on the line here so she can tell you a little bit more about the colloquium and all the wonderful things that are going to happen. I know we got CEUs and things. Kimberly, would you like to say a few things about the colloquium?
Hey, absolutely. How you doing?
Oh, I'm so glad to see you this morning.
You too. First, I want to tell you that was a great presentation. I am just impressed how you got so much in a short time. You are a winner.
Well, it's the Cliff Note version, you
Yes,
know, right?
yes. But yes, we're having the Jolivet Medical Institute Colloquium. Thank you again for being a presenter. And it's going to be a wonderful, wonderful presentation of elite presenters. We'll have 15 elite presenters, including you. And we also have 16 presentations where 16 CEUs can be earned. It's going to be $127, and that's $8.38 a CEU.
That's
Okay.
it?
That's it. That's it.
Whoa.
And then you also have an opportunity to add 3 additional CEUs. The wonderful Lexi has created me these coding games, and I love it. We have a modifier coding game we're going to play on Saturday, and an ICD-10 coding game on Sunday. That's November 6th and November 7th. And then we'll have live Q&As with some of our elite presenters. And so you have to be present for all of those to win the additional 3 CEUs, but that would make it 19 CEUs for that wonderful price of $127. So I hope that they can join us. It'll be a great, great positive educational experience.
Thank you so much, Kimberly. I can't wait. I'm super
Yeah.
excited.
Yes, me too.
Well,
Thanks for having
that's
me.
no problem. Thanks for coming on, Kimberly. It's such an honor to always have you on.
You
Um,
too.
So that wraps up our Coding with Christine Hall this week. I hope you got something really great out of it. Don't forget to go to our website, look at our upcoming events, make sure that you're signed up for the next Coding with Christine Hall. It's going to be in 2 weeks. And okay, fingers crossed, I need all my buddies out there. Our new office should be ready by then, and we should be presenting from the new location. So I look forward to that. I look forward to seeing you guys again. Have a wonderful day. Take care.